Okay.
So let's get started. We're going to lose our speaker if we don't. Two talks back to back for those of you in the class. One is one of the world experts on respiratory sensation, and to prove his point, he's demonstrating exertional dyspnea. In here. So Paul Davenport is also the chair of the faculty senate, and so he's going to have to be very on time. So make sure the questions you have, feel free to ask them. But by 10 of 4, I promise, he'd be out that door. Followed by Don McCrimmon, who many of you just met. So Don's expert in neuroanatomy of respiratory brainstem networks and has some interesting new data on the impact of metabolism-related hormones like leptin on that respiratory network. So we'll just start with Paul and say go because you're
it's fine. I'm sorry, I apologize. I'm leaving a meeting in which we were discussing your raise for next year. So I hope you'll forgive me for being a little bit late. There's a proposal, and so as your representative in that process, I always advocate that the faculty senate chair should get the largest raise, and anybody else can have what's left over. Yeah, darn, I didn't think of that. Daggone. Okay, all right, so I was asked to talk about dyspnea. So, I'm going to start with this. If you have COPD, it has certain signs that it presents with eventually. It's coming. It's just streaming in. So what I'm going to talk to you is I'm going to talk to you about the whole process of perceiving your breathing and dyspnea. Probably the second most common reason an individual is going to visit a physician is because they have a perception that they can't breathe. And so it's number 2 to pain. And then, of course, Dr. Bolser would like to remind us that cough is another reason. But sometimes it's breathlessness. So what happens is that patients often complain of the fact that they can't get their U-tubes to work. So we'll try it again, see if it'll load up. Okay. Try the other one, see if the other one works. So what I'm hoping to show you eventually is there's going to be two basic types of dyspnea or breathlessness. And so dyspnea is defined as difficulty of breathing. One type of breathing is the difficulty of breathing that happens when you're conscious. Another type of difficulty of breathing happens when you're unconscious. And so this one is actually a kid who has got sleep apnea. And the other one is COPD, and I'm not going to waste our time on that. But if you go on YouTube, there's some, one of the things we're doing is we're using some of these videos. If you just Google sleep apnea, you find some extremely frightening videos that you see. And my favorite part of putting this video, that's why I wish we could show the sleep apnea video up, is because when you watch this kid stop breathing, you stop breathing. Happens almost every time. So if you want to have play an experiment sometime, it's really kind of cool that when you actually watch a person with difficulty breathing, it causes you distress. One I'm not going to show was a video of a individual having a life-threatening asthma attack, and basically going into cardiac arrest from asthma. And it starts with this incredibly distressing sensation called dyspnea. Now, dyspnea is defined very simply as bad breathing, dyspnea. It's a subjective symptom of breathlessness. The American Thoracic Society has provided a very specific definition. It's the experience of breathing discomfort that includes a quality distinct to sensations that can vary in intensity. There's some problems with that definition I mean, in general, it's about right. The real problem is the fact that we have this term dyspnea, which almost defies definition, because dyspnea itself is multifactorial and multidimensional. So the paper I sent out was from Tom Simulowski's lab, in which they gave a very nice review showing that dyspnea is not a single symptom. Dyspnea is in essence a combination of symptoms that can have a variety of etiologies. And so to tease down what the origin of this breathlessness is can be very, very difficult. For example, I don't have COPD dyspnea, but I had exercise dyspnea when I arrived. So yes, I was feeling breathless, but that breathlessness has a different quality of a breathlessness that an asthma patient's going to feel, or a COPD patient's going to feel, or somebody who is actually having a heart attack can feel breathless. So these breathless sensations have multiple etiologies. And so the question is, how do we get a handle on what is really the dyspnea that we're seeing in individuals, and what are the neural mechanisms involved? So what I'm going to spend my time here is discussing what are the neural origins of dyspnea, and how can we study that and learn more about how we behaviorally breathe. For those who remember Neil Cherniak, like Gordon and Don and I, Neil Cherniak said at one time we spend 80% of our time awake breathing behaviorally. What that means is that we have an awful lot of cognitive involvement in our breathing, and one of those involvements is being aware of your breathing. And as soon as I say that, and I said you can be aware of your breathing, all of you just were, weren't you? All of a sudden started feeling your breathing. Why didn't you before? What changed? What changed was your attention. You changed attention to your breathing. So the sensory processing is there all the time, but what you do is you suppress, or I'm going to use the term gate out, that sensory information such that when you want it on demand, it's there and it's available. Sometimes you don't want it on demand, so that if you have certain things that change within your physiology, those inputs are going to change, they're going to increase, and what's going to happen is that you're going to get unwanted awareness of your breathing. And one of the last thing any patient wants is to feel their breathing. You always try to do behaviorally adjust your breathing patterns so that you won't feel it. There are two fundamental categories of ventilator dysfunction. Those that impede breathing, make it more difficult for you to breathe in. And then there's another one in which there are an increased elevated need for breathing. And again, different ways in which you have breathing. So if I give you carbon dioxide, you're going to feel a need to breathe more because this carbon dioxide is accumulating. That's going to create a sensation. That's very different than me putting an obstruction in your airway and making it more difficult for you to breathe. One is an impediment to breathe. The other is an increased need to drive breathing. So the difference between my breathing when I arrived, which was an increased need to breathe, if you will, because of exercise, that is going to be very different than the COPD patient who has an obstruction making it more difficult to breathe. So these are two fundamental types of dyspnea. Now, just to kind of give you, so that when I leave early, you can finish these slides on your own, give you the take-home message. Normally, what we have is we have a normal breathing capacity. And that breathing capacity is actually fairly large. For example, if I ask you to produce as much inspiratory pressure as you can, most of you are going to be able to produce about 80 centimeters of water inspiratory pressure. When you breathe in, you're using 2 or 3 in order to bring that air in. We have a tremendous ventilatory capacity, and we have a very low demand. And so under those normal circumstances, when I have high capacity, low demand, everything is fine. My brain says I'm happy. Remember, we breathe with our brain. Even though we talk about respiratory mechanics, we breathe with our brain. Hence, I have very little perception of a need to breathe if my normal capability is more than compensating for my normal demand. However, what if you have various types of lung disease? Now what happens is the demand goes up. And so let's assume that the individual has normal capacity, but now I increase the demand. in which I'm going to drive the respiratory system with. If I increase that demand enough, such as hyperinflation, bronchoconstriction, obstructions, infections, all of these things are changing the respiratory or breathing environment, and they're making the respiratory system have to breathe harder, increase their effort, if you will, or increase the whole process, the drive to breathe. And so that means that I'm now encroaching more and more and more on my demand and bringing it closer to my capacity. As you get demand and capacity closer to each other, such that you're using up your reserves, for example, now you add to that, for example, COPD is a good example of what happens is because a COPD patient has got a couple problems. They got a problem which they get obstruction. Okay? Then you add to that, hence chronic obstructive pulmonary disease. You add to that the problem of change in muscle mechanics. So let's say, for example, I have hyperinflation. My diaphragm is now at a more flattened position. Its ability to generate force is reduced. So now I have a reduced capacity because of the change in the mechanics of how that muscle contracts, and I have an increased demand. As those two start coming closer and closer, and I'm using more and more capacity, the brain is going, this is not sustainable, and produces a sensation of breathlessness. And what you're going to use that sensation for is you're going to use that sensation for behaviorally compensating for the difficulty of breathing. And that sensation that is generated, regardless of its etiology, that I'm not getting enough air, I'm not breathing enough, I'm having a difficulty of breathing, that is in essence this family of symptoms that we call dyspnea. Okay? Now, these respiratory sensations can arise from a variety of different patterns, and fundamentally they arise from an afferent standpoint. So I'm going to emphasize the afferent side, but you can also have central unexplained dyspneas. So I understand that that's going to be the case. Sometimes a person has normal mechanics, the afferents are just fine, but they feel breathless. And that's actually very common in certain diseases and certain conditions such as panic disorder, anxiety disorder. Some of these disorders, what happens is the individual starts feeling like they can't breathe when there's no reason for that to happen other than the central nervous system is getting a response that is saying, okay, I'm having difficulty of breathing. On the other side is you have an afferent system that is signaling the status of your respiratory system, and that has various modalities. And again, by modalities, you remember from your neurophysiology, there are certain sensory modalities in which you have sensors that transduce those processes, and those modalities can be either mechanical modalities, they can be airway caliber modalities, they can be lung volume modalities, and they also can be blood gas modalities. All these are respiratory-related modalities. These are primary respiratory sensory modalities in which you are monitoring all the time. And your brain is actually probably at this very moment processing that information about your lung mechanics. In fact, I can prove that by asking you to take a tidal breath. Go ahead, this is the group participation part. Take a tidal breath. How did you know that was a tidal breath? How did you know it went in? You had lung volume receptors that are feeding back to the brain saying, that's about it. And in fact, if I asked you to do that and I measured the volume, you're going to be about 80 to 90% accurate on that. The brain is able to access what's called a magnitude production experiment. The brain is able to process that information, say, okay, that much is inflation. So that means that you have to have a system feeding back to the brain that says, this is the volume change. And it has to be, and the brain can actually quantitate that. And so it can say, okay, yeah, that's about a tidal volume. If I ask you to take twice your tidal volume, you can do that. Okay? If I ask you to generate certain pressures, you can come fairly close in the calibrated pressures you can produce. These are all respiratory parameters. It's a little bit more difficult for me to ask you to generate an O2 or a CO2, but your brain, the point is your brain is getting this information and it's processing it all the time, and you can access that information. You can access it cognitively. And so you can look at those different modalities, and the really cool part about respiratory sensations is that each of those modalities is going to produce a unique type of perceived sensation, is in essence is the term. Each of those modalities is going to produce a sensation that is going to be distinct from another sensation. So that, and again, to me that's really cool, because now what I can do is I can differentiate between hyperinflation and increased blood gases. Now again, they're related, and it's not purely distinct, but I can differentiate between them. In fact, one of the real problems with behavior testing and respiration is the fundamental principle of psychophysiology, and that is the subject will always answer the question you ask. So if I ask you the question, are you feeling more difficulty of breathing, you will answer that. If I ask you, do you have air hunger, you will answer that. They may not be the same. If I ask you, do you feel hyperinflated? Do you feel, in essence, the question that I ask, you will answer, but they're not necessarily going to give you the same, they're not monitoring the same thing. And Donald Mahler and Richard Schwarzstein have made a very, very outstanding series of studies on using a cluster analysis of respiratory symptoms to find out what symptoms specifically cluster for each type of respiratory disease. And one of the things that's very interesting about that, I always find intriguing, is people, how do you know if you're having an asthma attack? There's only one symptom that almost exclusively characterizes to asthma, and that's chest tightness. If you ask somebody if they feel like they have chest tightness, if you're having an asthma attack or a bronchoconstriction event, the answer is yes, they feel that. Almost no other respiratory modality will express that same symptom. And again, the point is that there is in our language that we're communicating with about our respiratory status, physiology. So the physiology is basically producing the sensation that your brain is interpreting and communicating, if you're with a physician, saying, listen, I'm having this kind of a problem, or whatever. And it allows us to localize those sorts of parameters. What this also means, it implies, is that respiratory sensations have both a cortical and a subcortical neural basis for the perception of breathing, meaning that there are neural pathways involved in this. And that's what a lot of us find very interesting, is how can I trace out and investigate these neural pathways. And so the way we're going to try to understand respiratory perception and understand this dyspnea process, we're going to do that by probing the system and trying to selectively manipulate different aspects of the breathing process in order to get clues as to what parts of the brain are specifically interacting with producing what you feel. Okay? And the way that's done is it's done by a variety of means. Anatomical tracing usually can be done in experimental animals. You can do electrophysiological recordings. You can do a lot of brain imaging. And then you can do behavior testing. These are the usual tools that are applied for this. Interestingly enough, yes, animals can perceive their breathing. And we did train dogs back in the 1980s to signal detection of an obstructive load. And we only did it once because it took us 18 months to do 2 dogs. And so when you're trying to get tenure, that level of productivity is probably not real advisable. So we said, that's a great experiment. We loved it, and we're going on to something else. And the reason it took us so long is due to investigator naivete. So being a physiologist, I assumed I knew, and a young assistant professor, those are 2 things that combine to think that, yes, I know everything, okay? And so I knew all I needed to know about psychology because I trained under Dr. Zeckman, and he knew psychophysiology. And so I said, if you put a dog, and I put a endotracheal tube in a conscious dog, and I obstruct his airway, he'll press a lever to make it go away. And no, they don't. Dogs don't do that. What the dogs do is the dogs, when you obstruct their airway, they step back. Now, because I'm really, really sharp on these things, it took me about 6 months to recognize that. And actually I didn't. We had a graduate student at the time who said, but again, because it's my lab, I get the credit for it. But the graduate student pointed out, they're stepping back when you put the obstruction on. They're not pressing the lever. And so I always thought, well, rats press levers and then make food come out and that kind of stuff. A dog will do that same sort of thing. And it turns out that a dog wouldn't do that. They will not press a lever for anything. They're worse than cats I'm trying to train, okay, on that test. But they do step back. So what we did is we put the dog's foot on a lever. And we obstructed the airway, and when the dog stepped back, we took the obstruction away. And it took 1 week for the dog to be trained to do that and lift the lever and remove the airway. And then we could put graded loads. Now that was with pure obstruction, which is pretty easy to get a dog's attention with. But then we were able to use lower and lower levels of load, such that there were loads that were down, for those who know, remember, resistance is down around 2, 3, 4 centimeters of water per liter per second, which is about 70% of normal airways resistance. Dogs are able to signal detection of that. And so the answer is yes, animals can detect and they can respond to respiratory loads. Hence, they make a model in which we can use to study them if you have the time and you're already tenured. Now, the subcortical and cortical neural pathways are going to operate using shared modalities in the respiratory system. So you have a certain amount of receptors that are involved or modulated by respiratory processing or by the process of breathing. And there are two ways that information is going to be processed. One is going to be convergent sensory input, and the other is going to be divergent sensory input. So convergent sensory input allows the system to bring multiple afferents in and get a generalized sense that something's disordered. But when you have too much convergence, you have too little specificity. What divergence allows you to do is divergence allows you to select out specific afferent modalities in order to have one specific modality divert into a pathway that will only signal a specific type of modality, such as chest tightness. When you have bronchoconstriction with asthma, you have a whole bunch of afferents that are modulated, but yet you're able to differentiate asthma from say, lung hyperinflation. And that is because of the fundamental properties of sensory processing of convergence and divergence. You've heard this before. If you can't breathe, nothing else matters. That's actually the slogan of the Canadian Thoracic Society. So I'm going to give you certain assumptions as we move through the process of trying to understand our cognitive awareness of breathing. The assumptions are the respiratory disruption is going to result in a cognitive awareness. If you can sense it, you need to be cognitively aware. Neural processes mediate this awareness, hence it's a brain process. Sufficient disruption can lead to a distressing emotion. Respiratory dysfunction then motivates behavior and elicits behavioral adaptation, what I call behavioral breathing. And here the dog example works very well. What was the dog doing? The dog was trying to escape the obstruction. Now, Andrew, you have horses. One of the ways that we control horses, right, is we grab their nose. And what does a horse do when you grab its nose? Well, it holds its breath and tries to pull its head away. It tries to remove the obstruction, doesn't it? And so one of the fundamental features of distressed breathing is escape behavior. Okay? It occurs in animals and it occurs in humans as we try to get away from, and we can use that in essence in order to get the attention of an animal, or we can use that in terms of behaviorally adapting. Respiratory sensation of sufficient magnitude will dominate your awareness. One of the things that you often see is that a person, my best example of that is we were doing some experiments with up at the experimental dive unit, Navy experimental dive unit up in Panama City, in which they've got these big, huge chambers. They're on the surface, these chambers that they take you to different depths by pressure. And so they often train the aquanauts at 15 atmospheres, and they do it on heliox. And we were doing some experiments up there, looking at heliox breathing and that sort of stuff, doing some transdiaphragmatic pressure, some fun stuff. And I was chatting with one of the Navy divers, and they said, yeah, their record's 30 atmospheres. Yeah, exactly. So even on heliox, that's breathing mud. And so I said, well, what was it like? He said, you thought of two things, air in, air out. Because what happens is that their ability to perform their task was significantly reduced because the brain need to breathe dominated all of their sensory processing. And so what happens is that if your breathing gets bad enough, you can't think of anything else. And what is one of the classic escapes behavior of humans that have difficulty in breathing? It's a deadly disease. It's called immobility. What do patients do when they feel like they can't breathe? They're not going to climb the steps. They're not going to do their rehab because it hurts. And so one of the really difficult issues that you have to deal with when you're dealing with patients that have this dominating breathlessness is that they don't. In fact, I've had patients tell me, "Doc, I'd rather die than have to breathe like this." And so it's an incredibly distressing sensation, and it's highly motivating. We can divide this into two primary processes. And again, when you're reading the review article by Similowski's group, you notice that they talked about a multidimensional element of it. There is a discriminative process, there is an affective process, and then there's a motor behavioral response process. These are the three processes that they're talking about. What is the discriminative process? The discriminative process is the process by which you become aware of what's happening in your environment. It's the what, when, where, and how much information that the brain gets. That's going to be processed by the primary somatosensory cortex and primary somatosensation. It gives you a chance to just assess it, and it tells you what's there. The affective process is, what do I think about it? Do I like it or do I not like it? It's that element that you add that is part of the affective system that says, I really don't like this. This is causing me to feel bad, or this is causing me to feel good. And so the affective process is the second element, and usually they operate in sequence. First of all, you become aware of a change in breathing, and then you have an assessment of what you think about it. But that's not necessarily the case. Actually, the neural pathways actually operate in parallel, and so that you can be aware of it almost simultaneously with going, I really don't like this. Okay? And that's almost always what the patient reports when they have the affective report. They go, I don't like this. I would like to get rid of this. This is not good. Please fix me. Find the pulmonary pixie dust that makes my breathing good. Please. And that's literally what people are asking for. They want something that's going to make them so that they can return to normal in breathing. So, if a person is perceiving an increased respiratory difficulty, the first thing in our linear sequencing of it is the somatosensory event, the discriminative event. That gives me specificity. That's critically important, because if it's going to be a defensive reflex, you need to know what to defend. And it becomes an interesting argument. So I almost got pulled out the article for you to review was the 1962 Bennett et al., which was the first systematic study with Moore and Campbell's group on load sensation, in which they gave what they call elastic load. You're trying to breathe from a chamber, and as you take more and more air from the chamber, the negative pressure in the chamber opposes that air leaving, and that's called an elastic load. Since that time, all of those in respiratory perception have been arguing with great energy about what is breathlessness, what is dyspnea. And it turns out that what the real difficulty with the argument is the modality. And so if I give you an elastic load, which is this chamber, or if I give you a resistive load, which is like trying to breathe through a straw, you can actually differentiate between them. And that study's been done. It's been done showing that, yes, I can differentiate between not only an obstruction to breathing, but the type of obstruction. And so that is primarily done through the somatosensory system, that what, where, when, and how much type of information that the system is providing. So I can differentiate between that, and you can differentiate between that and a hypercapnic or a hypoxic load, which is going to cause you to change your breathing, but it's going to give you a completely different sensation. And so if I am a person who's doing loaded breathing, and I'm arguing with a person who's doing hyperinflation breathing, and we're talking about a respiratory sensation, of course we don't agree, because the mechanisms are different, but yet they're convergent. Both produce this sensation that's called dyspnea, but the modalities are different. And so is there a common ground in which we can all function with such that I can understand, when I understand the mechanisms of hyperinflation dyspnea, I can also understand some of the mechanisms of difficulty dyspnea or hypercapnia dyspnea or anything like that. And so that's one of our goals, is to move away from modality specificity, which we'll use to study the system, but we also have to move into a generalization of the neural processes. Your active evaluation of the lobe, which is the affective process, is providing a rather non-specific subjective impression, because what is the patient saying? The patient's saying, I really don't like this. That's what they're saying. And then you ask them, what don't you like? Well, I don't like the fact that I can't breathe. You say, well, what do you mean by you can't breathe? And so as you start probing the language, you're getting clues in the physiology of, okay, what do you mean you can't breathe? Well, every time I breathe, it makes my muscles hurt. Okay, well, it sounds to me like it may be something I would probe on effort. Or I can't get all my air out. Well, that sounds to me like hyperinflation. See how the language is now, the individual is actually able to process that information and give you some very good clues as to what the sensory system has been changed by and what the mechanical problem is. But they start with a very non-specific subjective impression that I can't breathe. Okay? And that's actually why people who cough go to the doctor. It's not because they're coughing, it's because they're having difficulty breathing, because the coughing interferes with their breathing, Dr. Bolser. And it's good to be in this position. It's good to be in this position because I'll hear about that later on. Okay. And then once you have all of the sensory processing going on, what you need to do is you really need to behaviorally adapt. And again, one of the fundamental behaviors we're going to look at is we're going to look at escape behavior. The other one's arousal. And so again, with sleep apnea, one of the real problems is that you have these obstructions of breathing, then the patient doesn't arouse. Or it takes a while for them to arouse. One explanation that is now that was tried for quite a while, it actually probably has some validity in sudden infant death syndrome, is that when neonates are born, they tend to breathe like cats. Okay, adult humans don't breathe like animals. Adult humans are what we call ventilation defenders. So what you do is you're going to adapt your behavior to defend your minute ventilation or alveolar ventilation. And so you're going to change your breathing behavior to defend ventilation. What animals do is animals will defend lung volume. And so they're volume regulators. So a cat in particular, if I take an anesthetized cat or dog and give them a load, what they're going to do is they're going to prolong their inspiratory duration and let their volume go, because in an effort to try to sustain that lung volume by increasing the inspiratory duration and then increasing the drive to breathing later on. What you might do in the same situation is you'll shorten your breath, breathe faster in order to maintain your alveolar ventilation, keep your gases constant. Okay? So it turns out that newborns, which we did here at University of Florida back in the 80s, why parents let us do this, I have no idea. But they would parents would let Phil Kosh and I bring 1 to 3 day old babies down to the lab over in the basic science building and put them up with electrodes, put a face mask on, and measure their breathing pattern with respiratory loading. And the IRB approved it. Okay, so we did get IRB approval. They didn't do it to my daughter, I'll tell you that right now. There's no chance I was going to, I'll do the experiments. In fact, my daughter does experiments with my breathing, like diaphragm needles and whatnot, but there was no way I was going to let them do that to my daughter. Exactly. Yeah. So we would bring these babies in. We do respiratory loading, and I had done years of loading in cats. And when we put the respiratory loads, inspiratory and expiratory loads on these newborn babies, their breathing pattern was exactly like a cat. Then, for some reason, the parents let us set him again at year of age, and now that's important. Did you know that? They made it to a year. Okay. So even though they came into the lab and we did our experiments, they at least made it to 1 year of age. We brought them in, and it turns out that they did not breathe like the volume regulating cat. What they would do is that if I gave them the same level of load, they would increase their ventilatory drive and their alveolar ventilation in order to defend gases. Sometime between day 1 and day 365, they transitioned in terms of their breathing pattern. Now, when that happens probably around 3 to 6 months. That's also the time when a baby is at highest risk of sudden infant death syndrome. And one of the hypotheses for sudden infant death syndrome is a baby, now now they have to have back to sleep, right? But back in the day, they would have bumpers and pillows and whatnot. And one of the hypotheses is that a baby would roll its face into a pillow, obstruct breathing, and not arouse. And then they would, in essence, go into loaded breathing and have a life crisis. And so one of the ways that was treated, if they would have this apnea, was to put electrodes on the leg. And they would monitor breathing with a belt if they were at risk, and if the baby stopped breathing for too long of a period of time, the electric current went on and the baby aroused. Now, it was very gentle. It was baby-sized electrocution. I mean, electrical stimulation. Yeah, they walk around with this twitch, this twitch in their leg. But it actually, in fairness, it was actually what does save a baby that's having that kind of a crisis is arousal. So when you have an obstruction of breathing event, arousal, increasing the behavioral awareness of your breathing, actually is protective for defending your ventilation. And I got a really interesting patient at the end of this to show you what happens when that's disrupted. So, some terminology that is evolved from that. First of all is respiratory exteroception. And what that means is that you have the ability to monitor the external environment in which you are breathing. And so the respiratory system has sensory receptors. And again, I'll give you, when I teach the neurophysiology, I tell the students, the only thing you know about your universe is what you have a sensor for. And so if you know about your respiratory environment, you have a sensor that monitors that. And so if you want to know about your respiratory environment, you either have to have one or invent one, which is much more difficult than having one to start with. The respiratory system has to interact with the external environment. It has to bring air in, it has to produce gas exchange, it has to do that by doing mechanical things with the respiratory pump. It has to have afferents that can monitor that, and those afferents, because you know that, has to go a place where cognition can occur, and that's usually the S1 and S2 cortices in the somatosensory system. Exteroception is really good because it allows you to localize where the problem is. For example, if I do this, the little sensor is going to be available to go like this, because you can localize where the problem is. So you need an afferent system that has sufficient discretion that allows you to localize where the problem is. Interestingly enough, if I give people a variety of respiratory sensory problems, they will all localize it right here, if it's internal. Why? Because they want, I want this airway cleared. And so one of the interpretations that the brain is making is that clear the airway. Clear that out. So that leads to a comment, well, that's because you're only sensing it in the upper airway. Not necessarily. It's similar to referred pain. If I have a sensory process, I can refer that process to where I think the problem is. So exteroception is monitoring your external environment. Interoception is really going to be, within the next few years, the thing that replaces all of this processing that we've been doing, the language that we have, because there's a whole evolving field of interoception, visceral interoception. And, we all have a lot of those types of interoceptive processes that are going on all the time. For example, when you have not had food for a certain amount of time, you have an interoceptive process that says, where's the donuts and seminar? I mean, I'm just saying, just asking, okay? I have a sugar sensor and a chocolate sensor. What it is, I have cell membranes that require significant chocolation periodically in order for them to maintain proper equilibrium. So there are other types of visceral processes in this visceral core that we're monitoring all the time. You may have had too much coffee, and certain sensory processes are saying, I need to do something about that too much coffee. You may have had a variety of things that allows us to monitor that under normal circumstances, but it also tells us when it's disrupted and when there's danger. That's interoception. Interoception has both the somatosensory, the discriminative, and the affective. It's also very much associated with autonomic control, and it's bigger than breathing. Breathing is just one of them. Yeah. Yes, it would be. Mm-hmm.
And then airway obstruction is extra?
Yeah, it would be, yeah. Unless the airway obstruction is, for example, tracheomalacia or something, or tracheal stenosis or something, laryngeal spasm. That would then be more classified as interoceptive because it's within the system. Bronchoconstriction is also an obstruction, but it's within the subject. Yeah.
Smell.
It's also interoception, yeah. Again, odor perception, but again, what you're doing is that's why these definitions fall apart. Okay, because we're trying to compartmentalize something that actually is integrated. So the process of smelling is an interoceptive process because you can actually sense different odors right now if you actually gate that information in. But you bringing odors into the nasal passages in order to identify specific odors, that would be more exteroception. Exactly. Yeah. But if you close your eyes, you can also see stuff. Okay, I see visions all the time. In fact, there are people I've talked to that are not necessarily in the room. That's humor. That's a great room to go into if you ever, when you close your eyes, you go into a romper room. It's a great place to be. Okay, so there are two primary interoceptive afferent pathways. And what is heavily involved in this is the insular cortex. The insular cortex is going to be a fundamental system that's involved in processing because interoception is heavily involved in how you feel about your respiratory system. The posterior insula provides the topographic information, modality specific for interoceptive signals, and that goes to the anterior insula. And the anterior insula is very important for the subjective feeling state. Bottom line, respiratory sensations, I hope I've been discussing, is a gated process. So what happens is you suppress that information so you gate out most of your respiratory sensation unless you need it. And it's all part of what I would call an urge to breathe system, which the urge comes from the drug abuse literature, in which there are people who study drug abuse have developed this concept of an urge motivational system. So why does a drug addict always go back to try to use that chemical again? It's because there's within the brain a certain processing system that develops this urge. And part of that then is then translatable into visceral urges. So you have an urge to breathe, and we invented a while ago, just because we didn't know what else to call it, an urge to cough. So you have these different visceral urges which motivate you to do certain acts. The critical nuclei, based on just looking at what processes have been involved, and we did actually this is brand new. I just working with a group in Tulsa who do a bunch of fMRI stuff on urges, and they're also doing some breathing stuff. And so what I asked them, I said, okay, what overlaps? What happens in different types of visceral system that's also happening in the respiratory system? And it turns out there's specific nuclei within the brain that overlap in all of those urge processing systems. Of great importance is the anterior cingulate and the insula, and they are connected through the medial thalamus, the hypothalamus, and various parts of the hypothalamus, which then also connect through raphe, PAG, locus coeruleus, which also connect to the brainstem. So the reason the colors are here are different levels within the central nervous system in which the information is processed. So you have your brainstem processing system, you have your midbrain processing system, then you have the thalamus, hypothalamus, and then you have higher brain centers for processing this urge to breathe. And one of the trigger elements is multisensory afferent modalities. So what are the fundamentals of afferent sensory processing? They have cognitive sensory events that reflect the neural process, sensory afferent transduction of respiratory-related parameters. So these afferents are transducing what's going on with breathing within the system. There is going to be a threshold at which you become aware of a change in your breathing. And then once you become aware of that, you are able to quantitate it. How bad is it? And you can scale that. That's for behavior. And then it's also modality specific. it's critically modulated by initial conditions. One of the things that's why I wanted to show you those videos. If you look at some of those videos, and I produce a feeling of negative affect, it's distressing. One of the problems of using affective modulation is you can't unsee stuff. So when we modulate affective state, we use negative affect, positive affect, and neutral affect. And so negative affect is usually very distressing images or distressing videos. And what happens is that that changes the way your brain processes your interoceptive information, such that if I give you negative affect condition, you'll feel worse about your breathing changes than if it's neutral or positive. Now, why does that matter? COPD patients usually have depression, very common with COPD. Asthma patients have anxiety. They're two sides of a coin, anxiety and depression, but depression means that they just feel rotten. They have this negative affect that's going on. And what happens is that they over amplify the negative element of their sensation because of their negative affect, and that has to be dealt with. So it's modified by initial conditions, and it has multimodal input, and it involves affective mechanisms. Okay, so afferents provide a multidimensional input of both internal and external stimuli. They transduce mechanical and chemical information. They're the only source for the brain to know what's going on. So the afferents are feeding into the brain, telling it what's going on. And then, of course, there are a variety of afferents that can involve, and we use divergence and convergence for processing. Now, those of us who've been in this field for a while, I ask you what are the most important, what are the respiratory afferents? Chemoreceptors, right? Vagal afferents, muscle-pharyngeal afferents. Turns out, if you really look, that's a small percentage of the total afferents that are modulated during regular breathing. For example, if I ask you to close your mouth and breathe in, what'd you feel? Airflow through the nose, exactly. If I ask you to open your mouth and breathe in, you feel the lung volume change, but you also feel the processing of the information through the buccal cavity. You can feel it in your pharynx. So it turns out that as we breathe, we have a whole bunch of afferents that are involved. The other one that I really like is that most of us are wearing clothing. Thanks for pointing that out. So when you breathe, attend to your shirt. You can feel your shirt move with the chest wall. Turns out if I actually record, one of the difficult experiments that we did one time, we were trying to record intercostal muscle afferents. Turns out I had to denervate everything except that intercostal space because the small vibration in moving the chest wall would vibrate pacinium corpuscles within the skin of the cat, producing an afferent response. So if you think about it, you know part of the way that you know you're breathing is all of this environment. You have abdominal receptors that are, yes, okay, I'm almost done. Yes, thank you. And so these are the different cranial nerves. So I went through the exercise and started listing the different nerves that were involved in this. And so there are a bunch of different, almost all of the cranial nerves actually are modulated by some parameter of respiratory processing. And they all feed into higher brain centers. Okay? We also have spinal input that's coming up into the spinal pathways because, you know, you've been studying it. You know what I'm talking about. You have intercostal, you have abdominal, you have phrenic, you have other inputs that are providing input that come into these brain pathways. So, sensory perception is going to be the result of sampling multiple afferent systems. And so the brain is going to sample all of this input. When I ask you to perceive your breathing, what happened? You were able to perceive your breathing because the brain now opened up channels, if you will, into the sensory processing, and it started sorting through all of those afferent systems, and it can sort through it and actually differentiate between difficulty, volume, pressure, in the duration at which the information is occurring. So I'm going to end with a couple examples and knowing my time frame. So unpleasantness. Turns out that you can have different types of sensory processing that are related to the affective system. One is the unpleasantness of the stimulus. Now, there are a group of people called adventure racers. Now, these are people that run 50 miles uphill both ways, okay? And you didn't know you could do that. Obviously, you haven't been an adventure racer. They run these 50-mile races in mountains. And so the question is, how do they do that? One of the things they're very good at is symptom suppression. They actually have reduced activation of areas of the insula that is suppressed, so they're suppressing some of their symptoms. Is this good? Maybe not. Because if I suppress symptoms, can I produce my self-injury? So this is giving subjects respiratory loads which are distressing. Trust me, 40 centimeters of water per liter per second load is distressing. Adventure racers were not bothered by it. Normal human beings are. Okay? And so it turns out that there is a relationship between the activation of anterior cingulate and the insula and the ability to tolerate respiratory load. And this may be gender specific. So if I give you a load and ask you to take 20 breaths against this load, it turns out that males truly are insensitive. Okay? Yep. And again, I didn't believe this data, so I had my graduate student repeat it with 10 and 20 breath loads. It turns out that it is probably correct that females tend to be more interoceptive sensitive. In other words, they're better monitors of their interoceptive processes than males are, because what happens is males can respond to an increased respiratory load, but they respond later and to a lesser extent than females do. It translates into asthma. Because if you look at the asthma population, there's two major groups that we worry about. One are anxiety, and the other is life-threatening asthma. These are kids that don't know they're having an asthma attack, almost always boys. And they're symptom suppressors. The incidence of anxiety and asthma is 17%, and the majority of those are women or girls. And so there may be a differentiation that is a function of sex related to how you process sensory information. So, take-home message. I listed the number of afferents that I could think of, and here's just a list of various types of afferents. They come in through cranial nerves and spinal sensory processes. So how does the brain work? It probably goes into second-order afferent integrator neurons, and what happens is all of those afferents are going to feed into a second-order system producing a specific neural processing that is going to be a function of the combination of those neural inputs. Then there is another order of activity in which those are then connected to subsequent pathways, which provides further discrimination due to sorting through this process. Then there are behavioral control assembly systems which can produce things like swallow, cough, hypercapnia, air hunger, hyperinflation, and effort, in which the combination of those inputs is going to produce that output. Those are going to produce either a discriminative process or an affective process. There's going to be a motor response that's going to come out of either the afferent integrator or the discriminative integrator or directly from the system. And with that, I'm done. If you're still going after 5, I can do that. Okay, I'll try it. Yeah. One question.
So on your adventure racers, yeah. Is that a learned suppression, or is that? I think it's DNA based. I think there are people that are just natural suppressors, is what I think. In fact, a case that we're just doing with recruitment also, we got We got a patient that had, actually had brain virus, herpes virus, 8 is insulin. And had gives on a 0 to 10 scale, gives us a 5 of 180 in blood level. And so I think there's something structural involved in that. That's why I would answer that question. And it turns out that patient doesn't load compensate. That patient, when you give them the load, just sit there and breathe, but let us CO2 whether brainstem's fine. CO2 goes up, O2 goes down, and the timing of the breath is prolonged, so frequency goes down, so they're not at a normal chemorreceptor response. As far as we know. Yeah. And so what that tells us is the higher brainstem is involved in the whole process. And my apologies.
We just saw an example of cough suppression. Since they're missing a sensor,
Yeah.
seems like there are major ways of getting these things out.
Yeah, and I think, you say, well, symptom suppressive is free. No, it's not. Because that puts these asthma kids at risk, because they're not sensing what they're looking for.
Well, thank you very much. A 10-minute break, and then we'll get started.
I do. Out the door and.